In 2008, nurses at the Southwestern Vermont Medical Center in Bennington began noticing that more and more infants born there were showing signs of opioid withdrawal at birth. The hospital wasn't able to care for them properly, and many had to be sent elsewhere for more treatment. Children born with neonatal abstinence syndrome, as the condition is known, start off their lives with fits of tremors, seizures, fevers, and intestinal problems. They require methadone or morphine to control their symptoms until their withdrawal is complete. The result is longer than average hospital stays and additional costs to hospitals. Opioid use by adults, whether it's prescription painkillers or illegal street drugs such as heroin, has been widely reported about for the past several years. Less well known is the impact opioids and their use and misuse have on newborn babies. A study released in 2016 by the Centers for Disease Control, the federal agency that monitors public health, shows Vermont with one of the highest rates of children born with symptoms of postnatal drug withdrawal from opioids. According to the CDC study, in 2013, Vermont had a statewide incidence rate of children born with opioid dependency of more than 33 children per 1,000 births, second only to West Virginia. The report covers only 28 states, and for some of the states, the data is incomplete for 2013. There is no national uniform standard on diagnosing children with the opioid syndrome. Making apples-to-apples comparisons between states is difficult. The Vermont Department of Health notes that the state's rates of overdoses due to opioids is similar to the national average, but our rates of children born with neonatal abstinence syndrome, at least through 2013, were more than 5 times higher. Vermont takes a more comprehensive approach to treating expectant mothers who have used opioids, whether as prescription painkillers or for recreational use, and that may account for the relatively high numbers of opioid-dependent babies born in the state. Not all babies born to mothers who are using opioids demonstrate symptoms of neonatal abstinence syndrome, and once weaned off the condition, they don't remain dependent and don't appear to suffer any observable long-term effects. But they do cost hospitals much more to treat than normal, healthy babies. Across the country, the total cost of treating infants with NAS is about $1.5 billion. Medicaid is by far the most common payer, covering about $1.2 billion of those costs. After the uptick in the numbers of kids showing signs of neonatal abstinence syndrome became apparent at Southwestern Vermont Medical Center, a partnership between the nursing staff, obstetricians, and pediatricians formed and developed a program known as Safe Arms. The program requires expecting moms who sign up for it to accept medication-assisted therapy, to agree to observation, and to make all their appointments. They are expected to attend support groups as well. Sheila Boney, who helped launch the program and who is now the SVMC's Administrative Director for Inpatient Services, tells us how it began.
So Safe Arms started by a staff nurse actually approaching me at the time if babies needed any kind of a pharmacologic intervention or if they needed medication to help them through with their withdrawal, we would have to send them to Albany Medical Center. We didn't have the medications, we didn't have the protocols, we didn't really know anything about treating those babies. The problem was at the time that the NICUs were very full of babies that had, acute medical conditions, and so sometimes they weren't able to accept them. And so we would do the best that we could here, so that kind of the non-pharmacologic interventions are swaddling and light, dim lights and a quiet environment and rocking and just things that you would think would soothe a newborn. But for some of these babies, that wasn't enough, and some of the symptoms that you see when a baby is going through withdrawal, they do a lot of rubbing. They have a lot of central nervous system symptoms. They have a lot of gastrointestinal symptoms, and it was very stressful for the staff to observe this in a newborn. And so one of them approached me one day and said, "We need to do this differently." So I partnered her with a clinical nurse specialist of the unit, and they did the research. They got the evidence-based practice guidelines and created the program that begins in the 28th week of pregnancy for a mom who's in opiate replacement program. They meet with their pediatrician, they meet with their obstetrician. We connect them with community agencies that can support them and their newborn. they're required to maintain their relationship with their provider who's doing the opiate replacements. And then we teach those moms and their significant others or their family kind of how to care for a baby that's going through withdrawal. Those newborns stay with us for 96 hours after delivery because the withdrawal period can be that long before you might see acute symptoms of it. And during that time, we teach the moms how to do the assessment and how to evaluate how the babies are doing. We engage them in that scoring. And it's not common that the babies have to have medications. Each newborn is very different in terms of how they respond or react to withdrawing from opiates. But both the babes and the moms are supported, and we haven't had to transfer a newborn out. I think the last baby we had to transfer out for reasons of withdrawal was maybe in like 2013. We've been able to keep them all in the community, which has been nice. Well, to the extent that the moms disclose and we're aware of what medications that they're on, we know and we can prepare for it. But there are times when women don't disclose, but the staff have become so adept at identifying these newborns that they'll recognize the symptoms of withdrawal even if we don't have a confirmed history from a mom.
So does a baby have to stay in the hospital longer than a normal?
They do, yeah. So a normal newborn will generally leave in about have a 48-hour length of stay, and these babies stay for at least 96. And then if we have to start them on morphine as an opiate replacement, then I think the longest length of stay we had was maybe 2 weeks, because we'll start them on morphine and then gradually wean them off.
So is this a long-term condition that the baby has to work through, or is it?
No, generally, once you've got them weaned, it probably would take 6 weeks, I would say, to have the complete withdrawal, be behind them. In terms of any sequelae that happen as a result of the opiate exposure in utero, I'm not familiar with any longitudinal studies yet. I'm sure that we've had conversations with UVM about trying to ascertain, what are the impacts, long term for these families. And it's hard because there's so many confounding factors to it. So to be able to say that, a mom and a baby who went through the Safe Arms program had a better or different outcome, than a baby that didn't have that resource. We haven't been quite able to figure out how we're going to just sort out all the variables.
So roughly how many babies per year would go through the Safe Arms program?
So last year we had, there were 35 opiate-exposed newborns. 28 of those moms were in recovery, so about 80% of the families go through Safe Arms. If they're not in a recovery program, or they're not interested in a recovery program, the same care is provided to the newborn, but that's a different conversation with that mom.
I was just wondering, do any of the parents or moms decline the opportunity to have their child go through the Safe Arms program that you're conducting, or?
For the moms that are in recovery, it is voluntary, absolutely. For the moms that are in a recovery program, they're usually very glad to have those resources. For moms who aren't in recovery, or for moms who don't feel like they can disclose what their medication habits are, I think they're mostly just frightened. I think towards the end of the pregnancy, I think many times women become very anxious about what it might mean for their newborn. And then if they're not in recovery, I think there's a very large concern that somehow the state would intervene, with their newborn. So.
Dr. Thamarj Small, an OB/GYN at the Southwestern Vermont Medical Center, describes the process through which pregnant women can avail themselves of the Safe Arms program.
Once the moms have been identified as having an opiate dependency, the next step is to define what the goals of the mom are for her health and her well-being. The vast majority of moms do continue on medication-assisted therapy, which is recognized as a gold standard by ACOG for maintaining women in early, good prenatal care, as well as to prevent withdrawal in the fetus and the newborn. So medication-assisted therapy would be either buprenorphine or methadone therapy. Different communities have different ways to address that need. In our community, we have a number of different centers who can provide that. In the early parts of the program, many of the moms that we had identified were moms who had already been identified through a variety of ways. Could be the legal system, could be through medical problems in the past. However, at this point, there's a strong enough word of mouth network among the moms that they're pretty clear that the program is here. Additionally, women are screened upon presentation with questions about their history of drug use, alcohol use, smoking, and a variety of other potentially deleterious concerns in pregnancy. At that point, many women will bring up, or perhaps even at the next appointment, they would bring up their concerns about their own drug use.
After they leave the hospital, many mothers who have used opioids find it helpful to continue to get help to control these conditions. The Rocking Horse program, a state-funded effort run locally by the United Counseling Service, is one option, say Kate Fox and Christine Willett, who run the program at UCS.
It provides a way for young mothers, young women, and older mothers who are working on their recovery to get support, to help them with their parenting skills and to support them in really being the best mom that they can be. So on that, from that perspective, it's a very hopeful, very resiliency, strength-based approach to this whole issue. It's an idea of expanding horizons because a lot of the women who are dealing with substance use or dealing with newfound abstinence and sobriety, social isolation is one of the big issues that we really see.
Absolutely, and that was one of the really strong components of the program is the amount of support that they get from each other. And that actually ties into what you were talking about with the children. They are a lot of the women that we serve are noticing that around the age of 4 and 5, they're really noticing a lot of significant behaviors that they're having a challenge, dealing with and knowing how to, do the best for them. So,
and that can be an impact again if you have been dealing with substance use as a young mother. Obviously, the impact of attachment, the child attachment, the idea of setting appropriate boundaries. If you have been dysregulated, if your emotions have been dysregulated by substance use, being able to teach the child, how do you regulate your emotions? How do you behave? How do you manage day-to-day life, basically?
Once children are weaned off of opiates, they appear to be able to function pretty much like any other children. But there's a lack of long-term data around this subject, those in the medical and education communities say. Robin Stromgren is the Bennington area's regional coordinator for Building Bright Futures, a public-private agency that promotes early childhood education and learning.
So this is actually a new phenomena that has grown exponentially over the last several years. So we do not have any longitudinal studies or long-term studies that will show us what happens with these children. Apparently, we're not seeing physical issues, but we're not sure about social emotional issues. And long-term wise, we know that children who have strong social emotional skills are able to be ready for school. It also affects their learning throughout their life. So it's a very important piece to have. And social emotional can be things like attachment, how somebody's relationship is developing, if they're able to self-soothe, self-control, and an initiative. Can they look at something and be ready to learn, find out how to do things on their own? So in Bennington County, we're looking at about 7.2% of our babies born at the Southwest Vermont Hospital. At this point, that if we talk about 400 births, we're talking about 28 children in a year, but that still there's a lot medically that needs to be watched and cared for. It is, again, as I'm saying, that sometimes it's the self-disclosure. Our hospital is now able to care for these babies instead of sending them to Albany, which is extraordinarily important in the bonding between a parent and a child.
In an effort to reduce or at least curb the opiate crisis, The CDC released its first set of national standards for prescribing painkillers this past spring. Sheila Boney agrees there's more that needs to be done.
So I think that there's a lot that we have to do within our community for both the youth of our community and for us within the medical profession to do better with how we're managing opiates in the first place before we'll start to see things trending down. I think the good news is that we have much higher percentages of people in recovery programs. And so the supports and the resources that are around them, because it's very few people who want to live with this addiction, it takes over their lives. So I think it's going to be a while before we start seeing any true changes.
For the GNet TV News Project, I'm Andrew McKeever.